get started for today's Crisis Jam. And again, thanks for bearing with us. We've gone through some growing pains a couple of times. We really outstripped the capabilities of Microsoft Teams and switched over to Zoom for the larger group when we were nearing 300. But we have about 600 people who are in the distribution list who are regular participants, and that's really broken the capabilities of Outlook with the calendar invites. You're getting barraged with notices. So we've moved over to a constant contact, and we're just in that transition right now. So bear with us while we figure all of that out. But essentially, Karen, if you can jump on for a moment. Karen, we've deleted the old Outlook invite. We've sent out a regular communication and let folks know what they need to do at this point.
Okay, so everyone who was in the invite before is now subscribed to the 90-day communications, Crisis Jam communications. It may, if it was forwarded and not on the main invite, they may not have received it. So those people will need to let me know so I can subscribe them.
Right.
The welcome email at the very bottom says download the Crisis Jam series. When you click on that, it should open up a calendar, download a calendar series. That's what worked for mine. And then you can save it onto your calendar. And then going forward, we'll be sending out some reminders and also weekly notifications so that you know when the recordings and the tools are up on the learning community on Crisis Talk.
Yeah, so Karen, typically, in the old system, I was doing a personalized newsletter on a weekly basis. So on the one hand, we want folks to go to the Crisis Talk website where all of these tools are easily accessed. On the other hand, we still want some kind of a newsletter going out on a weekly basis. So let's work together on automating that. So bear with us. Hopefully this will be smooth as butter as we move forward, and we'll get this worked out for this next iteration as we move with a larger group. So really excited about the presentation today. We teed up Freedom House with Stephanie Hepburn's Crisis Talk article, but we'll get more about that in our featured presentation with Dr. Eric Juan Rafla as we move forward. So Karen, let's go to the next slide. Margie Balfour, are you here today to tee up Margie's crisis meme for August 4th? Margie, are you with us? Paul, you have to step in for Margie if she doesn't pick up.
I happen to love Pawn Stars, so I love that she did it. This is my first time seeing it. It's clearly, for those of you that have watched the show, they operate a pawn shop in Las Vegas, and what they say in the bottom line is, yep, I hear what you want, and the best we can do, which is significantly less than what you want or believe you need, is regularly the answer for that individual. So I love that she went that way. I hear what you want and need, and the best we can do is this, which is what they're offering when you don't have a crisis.
Yeah, thank you, Paul. So I said to Margie, this one's hard hitting, Margie. It cuts pretty rough. And she said, okay, David, next time I will do something more positive. And I said, no, you keep doing what you do, Margie. That's the purpose of these crisis memes. So Margie, if you happen to jump on, we'll look forward to highlighting your ongoing work. Let's go to the next slide. No changes in our map from last time. We still have Office of Behavioral Health Leadership from all 50 states, as well as a number of counties across the country and local jurisdictions, whether it's cities or others, who are coming together with behavioral health leadership. And we've not yet made any movement in our Medicaid engagement. So we are going to be doing some targeted outreach to leaders who are already out there in the Medicaid space to help us to bring on some other partners. And if you're Office of Behavioral Health Leadership from states in the green, then maybe you already have a Medicaid rep on these calls or in this learning community. Let us know, or make an outreach, make a connection, and see if you can get somebody to join. These Medicaid partners have been critical as we've tapped into the resources available through the largest funding source in the country for behavioral health engagement, and especially this crisis space. So help us. We still haven't broken our June 23rd record. As we come out of the summer, hopefully we'll smash through that 300 barrier for which we got onto Zoom. So let's go to the next slide, Karen. We continue to update the Crisis Talk website with the videos of the presentations are all on there, as well as I've actually, you can't see it in this screenshot, but there are 3 little dots on each video at the bottom right, and that'll get you to the transcript where people have texted and chatted. And then the little, if you see right below the Community Weekly Calls, there's a link to the quotes, tools, and presentations, as well as Margie's Crisis Jam, our crisis memes. All of those are there as well. This is basically the template we've been using through Constant Contact to begin to try to upgrade for this larger group that we have now. So we'll be using this platform, and we'll try to, the whole purpose of this is to lower the level of barrage that was coming from Outlook. So we're going to try to simplify things, make it a lot cleaner and easier for all of you. So give us feedback depending on how that works for you. And again, hopefully this will smooth out as we make this transition from Outlook to Constant Contact. Great stuff, Karen. Stephanie Hepburn, are you on? We had Dr. Anitra Warrior a couple of weeks ago, and we have another representative as we were talking about Washington State and its work. We began to lean into some coverage of that topic as well. So Stephanie, do you want to talk about your interview with Vicky Lowe?
Yeah, so I don't think she's going to be able to hop on. She's at an all-day conference in Texas, but we did give her the information, so she might be able to later. I don't know. So Vicky Lowe is the executive director at the American Indian Health Commission of Washington State, and she shared some updates on the new crisis line and also the Washington Indian Behavioral Health Hub, which they'd been working on prior to the 988 legislation. It's a coordinating communication center that assists tribes and providers and acts as a bridge between tribal and statewide behavioral health and crisis systems. And there are a lot of nuances there that she goes into and the challenges navigating both. So this is a way to simplify and help people who are, providers, as well as people who are tribal members. So Washington State, we've talked about this before, but just, again, that Washington State's is creating a 988 tribal behavioral health and suicide prevention line. I know some other states are working on similar systems, but Washington State really is pioneering this. And they included $1 million in funding to develop and operate the line and a tribal 988 subcommittee. And what she talked about, what I think is really important, regardless of the marginalized communities in your state, she said, so often marginalized communities' voices aren't part of the dialogue on improving, expanding, or building systems that highly impact them. 988 gives states an opportunity to break the pattern and examine how to create an equitable behavioral health care and crisis system. And I think that's really the heart of her message, which is, states need to think about as they're given this opportunity to either build upon or expand or build different components of their crisis system. She said that states need to think about the populations they serve so they don't repeat the same mistakes. This is a chance, she said, to do something different.
Terrific, Stephanie. And I do see, Vicky, you're there.
Oh, great.
Hi, sorry. I'm in Texas and I live in Washington, and you guys are in, I don't know where, on the East Coast time, so I apologize. I thought you meant 2 o'clock this afternoon. Texas. Hi.
We're glad you're on, Vicky. Any comment that we obviously want people to read the Crisis Talk article, but any brief comment you want to make?
We're just so excited that all this work came together that we were doing with the tribes and with the state Medicaid program and Department of Health. And then when the legislators, when Representative Orwell and Representative Knopf realized that this would fit together so well, it was just so exciting that to see it get funded. Now we have sustainable funding for something that we're pretty stressed out about figuring out how to fund, but we were going to do the work because we know it needs to be done. So I just really look forward, and the call line has been getting more calls, I think, since I talked to Stephanie.
Oh, good.
There's been more of the tribal providers have been calling in, and the navigator at the hub and the coordinator have been going around and meeting with tribes and talking up the hub. And then eventually, you know, with the 988, it's just going to be great to have tribal people across the state call in and be able to talk to somebody who understands what it's like when it's very different to talk to someone in crisis when they're Indigenous. And I actually, in my work, I've gone with some of our tribal members to the crisis, the Behavioral Health Agency, and seen the questions and how our people interact with the non-tribal system. And I know how important it is to have somebody that understands what you're saying and understands your culture when you're in crisis and you call to get help.
Vicky also talked to me a little bit about the behavioral health aid role. Do you want to talk a little bit about that, Vicky?
Oh yeah, also just one of those things that we've been working on that's going to fit into this. When we were meeting with the designated crisis Responders Association and talking about the needs in Indian country, we realized that there's just a lack of workforce for the crisis care and just behavioral health in general, but specific to crisis care. The crisis responders in Washington State are really held tight by the revised Code of Washington to what they can do. Mm-hmm. And so we know that this workforce needs to be able to understand the population they're working with, but understand both systems of the crisis, both the Indian side and the state side. And so at the same time that we've been doing this work, the Northwest Portland Area Indian Health Board, which is a tribal organization for the 3-state area, has been trying to stand up this community health aid program. And part of that is the training and certification of behavioral health aides who have very specific training. And part of their training is actually working with the tribe that they're staffed from and understanding the culture, finding an elder to teach them, understanding working with trauma cases, and then also the actual system of care. So one of our ideas was, can we have these behavioral health aides also work at the hub? Can they be the people who answer the phone, you know, when you call 988 and push the right number to get someone who understands American Indians, Alaska Natives? So we're very excited all those things are coming together at the same time. That's why I know this is good, because it's all happening in the right way.
That's terrific, Vicky. Thanks so much for sharing that. And I think some of those comments on workforce are going to tie into our featured presentation. Thanks, Stephanie. Karen, let's go on to the next slide. And again, thanks Rep. Orwell for continued leadership in this area. Dr. Everett, are you with us today?
Yes, sir, I am. Thank you very much. We got a few announcements going on, and I see from my team a couple people here, so I'll try not to be redundant with what they're saying. So we're, over the next several weeks, going to really be focusing on strengthening up our communications strategy, and we are going to, be working with that. We'll introduce our new individual to this audience sometime in the next week or two. And we also are starting to plan, HHS divides up the country into 10 regions, and so we're planning some regional meetings that'll be oriented in partnership with CMS, and they'll be oriented toward focusing on funding related to the crisis spectrum of services, and will be inclusive of mental health as well as addiction. The first one of those will be regions 2 and 3, and we don't have a date yet for that. This is just an early announcement on that. I also have a small follow-up. So about a month ago, there was a question in the chat on this after a presentation from Nevada about the use of iPads and were they an allowable expense in our grants? And I did determine that they are an allowable expense in the CCBHC grant. So that's a small follow-up there. And then I would like to turn over to our chief strategist, Eitan Raskas, to give a brief update on, he has some information, I think, on the tribes.
Super.
And then we'll turn over to Richard Vicky, and he has some updates as well.
Great. Thanks, Dr.
Eitan?
Sure. Thanks so much, Anita and David. So a couple quick updates on the 90-day front. One, as Anita mentioned, I think we are increasingly organizing around a acting 90-day team inside of SAMHSA, which comprises a few of the folks on this call, in addition to the communications lead that Anita mentioned that we'll be bringing on. So I think hopefully additional dedication and bandwidth on the SAMHSA front, which should hopefully help us all fire on all cylinders going forward. Second thing, as Richard has noted in the past, both the Behavioral Health Coordinating Council as well as the White House Domestic Policy Council have active focus areas on 90-day and crisis more broadly. And so I would say planning on both of those fronts are ramping up, and there will be a handful of issues that get addressed in each of those forums that we will hopefully have kind of additional updates to bring to you on. But just want to highlight, I think, both the importance of some of those discussions and forums. And then I would say third, we are, as part of the broader work plan, are actively thinking about ways to provide some additional guidance and direction to the field. Obviously, the report is forthcoming later this summer, but I think in addition to that, SAMHSA is closely thinking through ways in which we can communicate both the vision for crisis services as well as the importance of 988 as a launch pad to that vision. So more on that to come, but just know that everyone in the field is eager and kind of hungry for more of that. And I think that is something that we are very much actively thinking about and taking into consideration carefully. And then maybe I'll just hand it over to Richard. I know you caught the entire tribal consultations yesterday. And if there are any updates you want to share, feel free to chime in.
Sure. Thank you, Anita and Eitan. So yesterday, there was a joint meeting of the SAMHSA and Indian Health Service tribal advisory committees. Both federal agencies have such committees in the interest of enhancing collaboration and coordination. These were done jointly, which I think was, a very important statement about this administration's prioritization of agencies working together to maximize our impact. And there was a section of the meeting that was focused on 988. So this was a really important opportunity for us to hear from an array of tribal leaders about their thoughts about 988, but more broadly about crisis services in Indian country. Some of the complex jurisdictional issues, that still have an impact on 911 in Indian country. The issues of a lack of bandwidth or ready telephone access in some areas. So this was really important. I also want to thank Sherry Sanuski from Vibrant, who provided a presentation and overview to the tribal leaders on some of the basics around 988, the timelines, what it is, how it fits into the lifeline, etc. So that was certainly an important meeting, and we will be following up with additional, formal tribal consultations, as well as continuing, to work with our federal partners at Indian Health Service. I was very glad to hear earlier in this crisis jam about the interview, which I'll look forward to reading, regarding the work in the state of Washington, where as part of their 988 legislation, they provided $1 million for specialized 988 related work for American Indians in that state. So in fact, I was in contact yesterday with Pat Morris at at Volunteers of Eastern Washington, who are playing a key role in that. So we'll be setting up a call with them to do a deeper dive in what they have planned, with an eye toward looking at the extent to which it could be a model for work elsewhere. You know, on the other front, on other fronts in terms of federal coordination, as Eitan mentioned, the Interdepartmental Policy Committee is continuing its work, looking at what needs to be done across the federal government and across different departments. Obviously, 988 is interdepartmental from a federal perspective in its essence, involving as it does the VA, but also the Department of Defense, Department of Justice, Department of Transportation, et cetera. And then the Behavioral Health Coordinating Committee, the subcommittee that on suicide prevention and crisis care, that's co-chaired by our Assistant Secretary, as well as the CDC Director, Rachel Walensky, is also setting up 3 working groups on 3 different areas. One is an HHS the strategy for suicide prevention. One is on comprehensive community-oriented suicide prevention activities, but the third is on 988 and crisis care. And so we have extended invitations to that across all of the HHS optives, and we are heartened by the strong response of other operating divisions and staff divisions within HHS who are wanting to participate on this. So we will keep you updated as that subgroup of the subcommittee convenes and the areas that it will be working on. So that's what I have. So thank you, David, and back to you.
Oh, Richard and Dr. Everett, Dr. McKeon, Eitan, thank you so much for SAMHSA's continued leadership here. That interdepartmental approach that Richard's talking about is really indicative of this emergence of SAMHSA as a central leader and ally across the government in this really critical time. So terrific work. Thank you. Dr. Brian Hepburn.
David, thank you very much. And thank you for all the work that you're doing. And thank you to Karen, along with you, to try and keep us, even though we're having growing pains, trying to keep us together. So constant contact, that sounds like a nice name for a platform. And I have to tell you, David, that I was able to get in, and I see myself as one of the poorest in terms of technical proficiency. So it worked okay for me. So thank you to you and Karen.
Right.
Want to thank Dr. Everett from SAMHSA, Eitan and Richard. I think the SAMHSA emphasis and prioritizing this issue is really great, and thank you for their leadership. I wanted to just give a quick update. States are working on post-COVID strategies, including 988 and crisis services. However, as we all know, COVID is still the major issue in most states, which really makes the workforce issue even worse because states are dealing with burnout in their public health areas. I don't think that public health has ever felt the attacks that they've had over the last year. And as a result, there are people that aren't willing to work in public health. So the more we can support public health and behavioral health, I think that's very important, working on recruitment, retention, and maintaining morale. I think that's one of the reasons I'm looking forward to reading what the Vicky Lowe interview, what Vicky said about behavioral health aides, I think is really important. We need to make sure that we're able to attract really good people to work in behavioral health. And with that, I want to ask Brian Sims to say a few words about trauma-informed approaches. Brian, he was having some technical problems, so hopefully he's still on. Brian?
Yes, yeah, thank you, Brian. I'm on. did a little flip-flop over to my cell phone so that we wouldn't be cut off, but thank you for this time. Actually, what Brian is bringing up is actually a mission and a vision that SAMHSA and NASPID has been promoting for a number of years. If you look into our bylaws and into our vision and mission, what you see is about the trauma-informed perspectives. So NASPID, in its regular monthly meetings, we meet with each of the states. We've been finding out more and more from the states that the implementation of trauma-informed strategies is not a new thing, but is seeing some new extensions and lights being turned on, if you would have it, in terms of how they're approaching the whole concept of crisis intervention, how they're communicating with individuals, how they're getting people to actually look ahead at access to care. And many of the states are now saying that they are looking for trauma-informed transformation strategies, which has become one of the elements that NASPID has been really pushing. And this goes to the front door of actually speaking to individuals, empowering them, talking about healing, talking about recovery, the whole implementation strategy of using peer support systems as a basis of really moving the system forward. And many of the states are now beginning to embrace that. Now, couple that with what Brian just mentioned about the reality checks that we're seeing through the media or otherwise, with the increased recognition that individuals' prior trauma are really playing out in the current, not just COVID components, but just in the recognition of the stresses that most people have had, either historically or culturally, that have now been made worse by the COVID and the post-COVID components. So it's I guess, a reminder to each of us that the trauma-informed perspectives are extremely powerful and very effective. And kudos to all of the states and all of those who are embracing this concept. And we'll continue moving forward to keep this as an open discussion issue and help as best as we can. Thank you, Brian, and thank you, Dave.
Thank you, Dr. Hepburn. Thank you, Dr. Sims. So the continued prioritization of crisis from Brian, from you and from NASPID, and this is 5 years running now. So it creates such a platform for that. We talked last week about step-by-step ferociously. So appreciate that. And Dr. Sims, this idea of care, feeling like care to the individual who's in crisis is such a transformational moment for us, and so appreciate your leadership on keeping that moving in the right direction. We're at RI are actually implementing, but Dr. Chuck, our Chief Medical Officer, and Ruchi, our Chief Operating Officer, are working together to integrate across our platform that guests will be asked routinely, did you feel cared about during the course of your services? Because that's and it's not a Likert, it's a yes or no question. So let's move on to the next slide, and let's keep that going. Those are great themes. We're going to skip over Tanja for today, given the time. But if you haven't seen Tanja's video yet, I encourage you to go to the Moving America's Soul on Suicide website. Today's quote, I actually ripped one of Eric's slides. He's maybe giving away the punchline at the outset, but a powerful statement: the safest communities don't have the most policing, they have the most resources. We're going to get into that presentation here in just a moment. Next slide. Sarah Corcoran, do we have an update at the national level as we move into a pause here pretty quickly?
Yeah, absolutely. So very quickly, the House wrapped up their labor HHS bill last week. They voted on a minibus for FY22 that includes a group of bills, not all of them, but a group of them, including that HHS bill, and they are now out for recess. The Senate began their appropriations process earlier this week with 3 bills. The HHS one was not one of the 3 bills that they marked up and had the full committee hearing on today. So we'll expect that when they come back in September. Right now, they're working on an amendment process for that bipartisan infrastructure package. And Leader Schumer hopes to also have a vote on that budget resolution for that $3.5 trillion package before they break for recess. They are scheduled to break this Friday. That's not going to happen. We're now looking more likely at next week, but Leader Schumer is hoping that the pressure will get to them. They'll get sick of each other and make some moves so that they can break for the rest of August, which is actually not a bad tactic. And then finally, I'm going to drop into the chat a link to a Politico magazine article that was featured last Friday, talking about the Ann Arbor, Michigan crisis response system that they're building up and trying to transform, also juxtaposed to a story of somebody there named Anthony Hamilton and his mom, Cynthia, trying to navigate that justice system crisis pathway for themselves over the past dozen years or so. So it's a really long article, but it does show the continued focus, especially in the DC Hill-facing media, on crisis systems, the coming 988 system, and what it looks like to have to try to navigate that system.
So Sarah, are you suggesting we bring the 988 learning community together and we can't leave until we solve the 988 and crisis continuum? Is that?
It's a good tactic for Senate because they're tired of each other, but I think it's going to take, we're all dedicated. That's not a question at this point for us.
Great stuff, Sarah. Appreciate your ongoing leadership here. And again, we talked a little bit about the recess period, getting into some targeted strategy primer building sort of work. So I look forward to talking with you more about that. Speaking of us beginning to get into a lull, there is one color change on the map. Laura Evans, are you with us?
I am. Thanks, David. And I want to also thank SAMHSA for their very thoughtful consideration of the various communities and how we can better serve them. And I just am very encouraged by all the work being done on that and also at the state level. I do want to thank Margie and Vicky for highlighting the work that was done in Washington State and everyone really who carried Washington State's legislation over the goal line. And I know Vic last week spoke to the Texas Suicide Prevention Coalition, highlighting issues of equity. And this is just so important that I do want to take a brief moment to just acknowledge that and thank everyone for their work on that, and much work still to be done. For the map, we're very excited to have Oregon now in green. Their bill was signed into law last week. So that, yes, very great news. And I apologize that I was not here last week to deliver that news, but hopefully we could, if there's anyone from Oregon who wanted to talk about it, I think it's just great. They did have a study for the 988 fee, so more to come from that. We're still waiting for New York bill to be signed. That has passed both chambers. I think the New York governor may be a little bit busy right now with other items on his plate, but we are still waiting for that to come through. California, Massachusetts, and New Jersey are still active. No new changes there. So just a lot of activity. I also want to note too, for the states that have passed studies or are informally bringing stakeholders together, I think it's really important that we do ensure that marginalized communities, that the crisis centers are a part of those conversations. So this is just kind of a pitch and message to say, if your state is beginning those conversations, make sure that you are a part of those conversations. It's much easier to be in the beginning stages of legislation than trying to go back and reformat legislation or miss the boat entirely. So I think it's really important as these conversations are being held that we are elevating the voices of those in marginalized communities and those who are doing the work in the crisis centers and crisis teams. So that's all from my end. I don't think there's any more updates from the states, but happy to see if anyone has more to add.
That's terrific, Laura. Angela Kimball, anything you would add from NAMI's perspective?
No, actually, Laura just did such a beautiful job as always and was quite comprehensive. So thanks.
So, Paul, I'm going to take the chair's privilege here and skip the 5 seconds of crisis calculator today, given our time constraints, but we will come back to the crisis calculator this coming week. And I'd also like Laura and Angela, Paul, I'd like us to think through as we get into this recess period, maybe a marriage of the crisis calculator and a state-by-state view. So for example, next week, we would pick one of these states in the green that has already passed legislation and begin to look at the forecasted needs from the calculator and the funding that we believe is coming to bear from the legislation that's put into place. So we start to get into each of these states and maybe look for a comment some feedback from the state itself. So let's brainstorm that and see if we can pull that off in the next couple of weeks and talk with our SAMHSA and NASBID partners as in the steering committee, Dr. Everett, Dr. Hepburn, think through that as a template for us to begin to go through. We've already got now, looks like 8 states that are in the green and 2 that could potentially follow, which would carry us through the next 3 months as we went week to week. So let's explore more on that. So Karen, let's shift through to our featured presentation. You did see Karen skip over that slide real quick of the mobile crisis Medicaid funding, which it looked from my quick view was due in the next 10 days or so. Is that Tom Betlock or Vicky, anybody want to jump in on the
That's
closing
correct,
time
David.
period?
I believe it's August 12th for the $15 million grants. So that is coming up within the next 8 or 9 days.
Terrific. And Karen, go back one slide if you would. And Eric, I just shifted it out of order just a bit here to set up the stage, but we did quote unquote meet Eric by virtue of the media attention on this New England Journal of Medicine article. Karen and I outreached Dr. Rafla-Yuan the next day, actually, and I think he was on the Crisis Jam the day after that. So we're so thrilled to have Dr. Eric Rafla-Yuan after this tremendous decoupling crisis response from policing, a step toward equitable psychiatric emergency services, to be a guest on our Crisis Jam and today with the featured presentation. So Dr. Rafla-Yuan, the floor is yours. Please help us with thinking through some of these key issues and how we move forward.
Thanks, David, for arranging the talk. Can you hear me okay?
Excellent. Okay,
great. So like you were saying, my name is Eric Rafla-Yuan, and I'm now here in DC as the American Psychiatric Association Jeanne Spurlock Congressional Fellow. Today, I'll be discussing how 988 itself advances equity and what purposeful decisions were made to ensure that we keep moving in this direction. I also wanted to take a couple of minutes to review a couple of important highlights from the New England article. Could we go to the next slide? But before we get to that, I just wanted to say what spurred me to write this article was the events of 2020 and where it was so clearly displayed across the nation how combative the relationship was that police departments had with Black and other minority communities. And while it had always been uncomfortable for me and many of my colleagues to recommend patients in crisis call police for aid, I could no longer do so after that in good conscience. And I also saw parallels in how the Black community in Pittsburgh developed their own emergency response system to what we're seeing now with 988. And so some of you may know a little bit of this history if you've read this article, but prior to the late 1960s and 70s in most places, police and sometimes coroners or funeral home staff responded to medical emergencies. So whether you had a heart attack, a stroke, or what was increasingly happening were car accidents, police responded and only provided transportation in the backs of their police cars. And the medical world did not consider individuals in need as patients until they arrived at the hospital or clinic. And this is where psychiatric crisis response still is today. Next slide, please. And so in Pittsburgh, in the 1960s and 70s, police were deprioritizing or not responding to calls for medical emergencies in Black neighborhoods. And so the Black community, including James McCoy Jr., who was a local NAACP leader and also president of the nonprofit Freedom House Enterprise, which was an employment assisting organization, partnered with the University of Pittsburgh, physicians from the University of Pittsburgh to develop their own community-based solutions. And so the physicians who worked with them were world famous anesthesiologist, Dr. Peter Safar, who actually invented CPR and thought that Freedom House was an ideal opportunity to develop to implement some of these new techniques in medical training, as well as critical care physician Nancy Caroline, who later joined as the medical director and advocated to the American Medical Association that physicians needed to respond to patients in the streets. Next slide, please.
So Eric, this understanding of the way that we use police to respond to medical emergencies, I mean, it makes sense now that you say it, but how did you come across this?
So it is like many other stories in Black communities, wasn't really a great history. A psychiatrist actually named Matthew Edwards went to the medical archives in Pittsburgh and Harvard and unearthed some of the story, which he published a few years ago. But going back in some of the emergency medicine journals, this history is there, just hasn't really been widely spread or talked about.
Yeah.
So coming back to 2021, police still respond to our mental health calls, and what's wrong with this picture. And so police response leads to incredibly poor outcomes, which aren't improved even with further training. And part of the reason why is that police are oriented to law enforcement and safety and respond to mental illness as a threat to be neutralized. And the best response perhaps that we can expect from police in an acute situation is that they provide transportation to the hospital. So back where we were in the 1950s. And this criminalizes our patients figuratively and literally. So having a criminal response team come to psychiatric emergencies furthers the stigma and the idea of mental illness as criminal. And additionally, literally, individuals who call 911 for psychiatric aid run the risk of being charged with criminal or civil offenses, which happens not infrequently. Police also have a long history of structural racism and individual bias in the police force. And you all had a great presentation on the racist history of the 911 number a few weeks ago, where you saw a driving force for the 911 number's development in 1967 was to mobilize police to quickly respond and extinguish civil rights protests in the 1960s. Police forces were also originally developed to maintain a racialized social order and protect property, and have been weaponized against Black and minority communities, and also increasingly are funded at the expense of community health and social services, where that limited funding pot is sent to police to maintain safety in the community rather than to provide resources for that community, which really was the thrust of the quote that you had earlier. And is incredibly expensive. So interesting statistic, the United States Police would rank third if it was ranked against military budgets of countries. So a concluding point of our article discussed intersectionality, where the stigma of mental illness confluenced with racism to place Black individuals at an exceptionally high risk for police violence, as police were called, for a crisis encounter. And so by decoupling mental health treatment from policing, we can improve equity, not just for those specific individuals, but broadly for all patients with mental illness, as well as Black and other minority individuals and communities who are seeking mental health services. Shifting now, looking at equity and mobile crisis development. And also shout out to Margie Balfour for this amazing infographic, which has been so helpful during my meetings with legislators, and I'll use it again here. So structural racism influences every decision made in crisis response. So how 911 dispatch protocols are developed and who's dispatched, how police interact with those individuals when they arrive on the scene, what custody and charging decisions are made, where individuals in crisis are taken, are restraints and handcuffs used, and if so, for how long, in what manner, are individuals in crisis able to access hospitalization? If so, what is that experience like, and what resources are available after the crisis? So we need to make sure that we're making intentional, actively anti-racist decisions, because the system is going to go by default in the opposite direction. The 988 number itself represents an incredible opportunity to decouple crisis response from policing, because you're literally not calling 911. But this will only be realized if the full crisis spectrum can be implemented, including non-carceral stabilization centers and adequate follow-up resources. 988 loses some of its shine if police are still the most likely ones to respond, and there is no ability to access meaningful treatment after you've called 988. Some specific equity challenges that are arising as jurisdictions are attempting to operationalize these teams. How is dangerousness and severity defined, meaning who gets clinical teams versus who gets police? How will lower resource communities stand up crisis services if they're not able to fund it on their own? How much voice the community has in its decision? The last few I really want to highlight. So avoiding default co-responder models, which are still policing oriented and situated in managed, supervised by police departments. And if they are used, reserving them for the highest risk calls. And also how the clinical teams are composed and developed. As we heard earlier today, has been a challenge as the workforce is already so limited. And so as we look to develop equity in our mobile crisis workforce, we know there's a huge shortage. There's not just a shortage of mental health clinicians, there specifically is a shortage of clinicians trained and able to work the hours required for our mobile crisis response teams. Another thing in the training, currently existing programs for master's level clinicians, which are the most popular model right now, generally emphasize long-term outpatient treatment in a more stable clinic environment rather than a high acuity triage in a resource limited setting. Interestingly, these same challenges arose in the 1960s and 70s when EMS advanced all of the emergency medicine professions that we know today. So EMTs didn't exist when EMS was first introduced. Their skill set was defined to meet the need. And so I'll go through a little bit of that because I think it's quite interesting and relevant. So the EMS Systems Act was passed in 1973, which mandated and funded nationwide infrastructure, including dispatch systems, paralleling what we're seeing with 988 today. In 1973, the American Medical Association voted to approve emergency medicine as a new specialty, which was distinctive from pre-existing specialties by its interaction with the EMS system at every level. So from EMTs handing off patients to the emergency medicine residents in the emergency department, to those same physicians being the medical directors of EMS systems in different cities and counties across the country. I'll also point out that the push for this new specialty was changing infrastructure and demand rather than an increase in the body of knowledge or new scientific developments, which are the cause for the formation of most other new medical specialties. And so some equity challenges with our current mobile crisis workforce. So clearly an improvement over police due to the clinical orientation, but our available mobile crisis clinician workforce is also limited in representation. And mental health professions in the mental health system have a poor history in working with some of our vulnerable communities. And so this has led to tensions in some communities between community centering and professional credentialing, with some community advocates wishing to avoid mental health professionals altogether. And so this leading to an example like a pilot program in Oakland where the community wished to avoid mental health professionals and treatment altogether, including hospitals and psych wards. And so this can lead to other forms of inequity where it's harder to access treatment and perhaps some of the folks who are most in need aren't able to access the training and skills of psychiatrists, therapists, et cetera. But part of it's arisen out of this sort of false dichotomy between community centering and professional credentials. Next slide, please. And so this has led to what myself and others are calling mental health first responders. And so they've also been referred to as psych EMTs, psychiatric first responders, behavioral health first responders. And the skill set that would be emphasized is there on the right, and it's what we saw earlier, a new clinically oriented skill set to match the need, possibly mirroring the 6 to 12 month curriculum length of EMT programs, importantly not supervised by police or located in police departments, and with constant team-based access to clinical supervision. But this would really increase accessibility to professional training and employment, would open the pathway for community-based professionals so that those individuals from that community could work as professionals and serve in that community. Also, it would help us more quickly increase workforce numbers. And so some questions I've gotten, well, how are these different from peer support specialists? So mental health first responders would be distinct and complementary to peers. So by not limiting this pathway to those with lived experience in psychiatric illness or substance use disorders, it would draw from a different and wider pool of individuals. So people right out of college, people who didn't go to college, these would all be people who could do EMT if they wanted to work in the EMS domain, but there is no current available possible employment opportunity for them to work in the mental health arena. And so this would open that pathway for them. This also would acknowledge the value of both professional training and lived experience. And so a possible team setup could be a behavioral health first responder with a peer on that 2-person team with constant backup or availability of backup by that licensed mental health clinician. And so this is a much more practical use for the numbers that we have. It also gives us an opportunity to center our communities. And so getting to our conclusions, so 988 offers us a once in a lifetime opportunity to couple crisis response from policing. And simply shifting away from 911 and to this 988 number advances equity for many groups as long as we have the resources to adequately stand up that full spectrum of care. And additional purposeful decisions are needed to create a more equitable system, and defining skill sets and increasing opportunities for community-based professional employment will advance the effectiveness and equity of our mobile crisis workforce. So then I just had ended with my quote that David had shown before. The safest communities don't have the most cops, they have the most resources.
Wow, Eric, tremendous presentation, lots of great comments in the text and chat. And I just want to draw out a couple of things real quick. The slide that you have on the difference in a clinical mindset for a typical outpatient community behavioral health setting versus a crisis triage setting, that's tremendous. You spent like less than a minute on that, and I'd love for us to do even a featured presentation on just that concept at some point. Really, really critical. The other thing is I dropped in, we had seen a timeline on EMS development back from a presenter at a 988 planning meeting a couple of years ago now that we used to develop the Crisis Now timeline for behavioral health crisis. But now looking back at it, you've provided so much context for things that were on there when I first saw it but didn't understand. With Freedom House being highlighted on there in 67 and the first 911 call happening shortly after that, that those two things happened separately. Freedom House even predating. That's really terrific. So Eric, you'd mentioned a roundtable from a couple of our key partners. We haven't heard from Matt Goldman since his pictures of his beautiful newborn. Matt, are you with us?
Hey, David, nice to see you.
Glad to have you back.
It's good to be here. It's good to see many familiar faces back on the call. And thank you so much, Eric, for the opportunity to just reflect and comment a little bit on your talk. It's great to see you here and to see all the important contributions you're making in this space. So yes, first to just reflect, I think you raised such important points about how this is such an opportunity to really advance anti-racist policy in mental health services just by virtue of standing up an effective 988 system, an effective, SAMHSA guidelines informed type Crisis Now model. A couple thoughts on measuring impact on equity and holding accountability to make sure that these interventions are actually advancing equity in systems. If you can't measure it, you can't manage it, right? So you got to be able to have some numbers that inform whether implementing a crisis program is actually moving the needle on improving access to care for Black and Brown populations, for BIPOC populations. And so I would say just, further reflecting on this, that developing a plan for routine and accurate collection of race and ethnicity data as part of standing up a crisis program is essential. You're not going to be able to demonstrate equity unless you're actually able to measure race and ethnicity. Now, we know that that's not necessarily easy to do during a crisis encounter because, police are trained that they can describe race ethnicity observationally. Mental health clinicians don't tend to do that. That's not our role. We're much more inclined and trained appropriately, so I believe, to ask a participant for a service recipient for their own self-reported race and ethnicity, and that might not always be feasible or even appropriate to ask in the midst of a mental health crisis. And so strategies for getting around those obstacles, there are a couple things to consider. One is training of crisis staff to ask those questions in a sensitive way during a crisis encounter. This is something that can be taught. it's challenging, but it can be taught. And so I would encourage programs as they're thinking about advancing equity, you got to be able to learn how to actually ask those questions to really be able to measure this data. And secondly, if it's not feasible to actually ask those questions, having strategies to at least get basic identifying information so that these crisis data sets can then be linked to other types of data that already have race and ethnicity data in them. So for example, Medicaid eligibility data or those kinds of things that might have race ethnicity, so that you can then draw on that information to be able to interpret impact on equity. That's the only way that we're really going to be able to make sure that we're incorporating equity analyses into quality improvement activities, evaluation activities, using either descriptive sort of stats or even getting fancier with things like stratification, really being able to measure the differences in impact on BIPOC populations. And so, just wanted to share some of those reflections on how to kind of concretize some of what Eric is saying to really make sure that we're moving the needle on these important issues.
Terrific, Matt. Disaggregating the data is going to be the key for whether or not this is real or just what'd you call it, marketing, Matthew, in your Crisis Talk article. Let's go to Amy Watson. Dr. Watson, are you with us?
Yes, I am. Great to be here. And just to kind of add to what Matt said, another way of really looking at equity is as we're dispatching either through 988 or 911, if we're dispatching various crisis teams or police, we can look at and map where we're dispatching different types of teams. Yeah. So we can look at which communities are getting police more often versus a crisis team. So that could be a good way. But I wanted to kind of follow up a little bit on what Eric had talked about with our workforce shortage. And, part of it is we just have a shortage in the mental health workforce overall, but we don't have a workforce that's prepared specifically to do this type of work necessarily. And so some colleagues and I, Michael Compton and Leah Pope, at the Law Enforcement and Public Health Conference in April, we actually put together a panel that included 911 operators, law enforcement, people with lived experience, family members, and mental health providers to walk through some scenarios that were sort of escalating a little bit in terms of risk and asking about what is the skill set that a responder needs in these situations. And, really a lot of what people talked about was the ability to engage with someone who's in crisis, to de-escalate, to develop a sense of trust with that person, and really to be able to assess that person's immediate needs, which often relate to various types of social service needs. They talk more also about, as the scenarios got a little bit riskier, about perhaps needing to have law enforcement on standby or law enforcement involved. And so we're actually going to do a second panel at the CIT International Conference, which will be in Phoenix this month, where we're going to try to drill down a little bit more into what are the safety skills that responders need. So how can we prepare non-law enforcement responders to handle many of the calls that currently are going to law enforcement? And even as I talk to people about sending non-law enforcement teams, sort of the linchpin is always when it's safe to do so. And some of it just has to do with the preparation of the responders that we're sending. Certainly there's situations where we may need police there because there's a weapon in play or there's a specific safety issue. But for many of these types of situations, we can prepare responders to manage the scene and assess safety and know when they do need to back out and request assistance. So that's what we're really working on. And after the LEPH panel, that's where I actually connected with Eric and some other people that are looking at it as well, to really start to develop what are those skill sets that we need. So how can we put together training that to really prepare responders and get them into the field. And if we can develop something that doesn't require a master's degree, which I don't think you need a master's degree to do this work, then we can develop programs that really allow for rapid entry into the field. And we can prioritize people from the communities that have been disproportionately negatively impacted by policing. And so we can really bring people into the field and be more responsive to the concerns of those communities. So I think that's going to be really important, is making sure that we develop a workforce that looks like the communities that are really asking for this the loudest. So that we don't want police coming out. We want some alternatives, and we don't necessarily want master's level clinicians, but we want to build a response that meets our needs and allows us to access care when we need it. So I really actually sharing Eric's article with everybody that I know.
So Dr. Eric Rafla-Yuan, terrific presentation. Thank you so much. If you're a state or national organization looking for key allies from a research standpoint, we've obviously had Dr. Joyner, who's on today, as a key partner in this work, but Dr. Goldman, Dr. Watson, Amy, you also referenced Michael Compton, who's also terrific. And I think these brief comments show you how much insight is packed into these presenters. So thank you so much. We have just like a minute left, but Richard, you pointed out I, in the time crunch, skipped over AFSP, and I do want to get a reference to the two bills you were referencing. Richard, is someone from AFSP on to do a 1-minute recap of the other work that's going on?
Hi, everyone. It's Natalie here with AFSP. I just put a comment down in the chat. The National Suicide Hotline Improvement Act was marked up yesterday, as well as the Stand Up Act. I don't have an update on the Stand Up Act, and we'll work to be able to provide an update at our next meeting next week, and we'll contact some of the folks leading that legislation. It sounds like the National Suicide Hotline Improvement Act did have a manager's amendment put in place, and that was going to look at the funding mechanism that was in the original bill that passed out of the House, and hopefully I can report more on that as well.
Terrific. Thank you, Natalie. Richard, do you want to make any final comments today? For those of you who had challenges with getting on the call, we did address that we're shifting over to a new platform, hopefully to make all of this a lot easier with the larger group. So stay tuned for more info. But Richard, any final comments?
Just again, thank you, David, for today's featured presentation, for arranging that and for conducting this. This effort, as we've said at times before, it's in a generation, not a once in a lifetime opportunity to improve crisis services in America. And for that to happen, we all need to be engaged and involved in that. And I think that this meeting keeps us all involved and able to see what we each can push forward to our own capacity. So thank you, David.
Thank you all. And we are looking to expand our pipeline. So featured presentations, Dr. Watson, Dr. Compton are people that we'd certainly be outreaching to. Eric, we'd like to definitely have you back, and please let us know your ideas. Thanks so much. Take care.